Welcome to PFT Tutor with Jeffrey Haynes. Please click the like, subscribe, and notification buttons. It's greatly appreciated. In this video, we're going to discuss a common error encountered during spirometry testing, excessive back extrapolated volume. We'll discuss what it is and what you can do to correct it. So what exactly is back extrapolated volume? The first concept to understand is that any spirometry value that is timed, like the forced expiratory volume in the first second, FEV1, or others like FEV3 or the forced expiratory time, need to start at time zero. In other words, the computer software needs to determine when the forced exhalation begins, and that will be time zero. The spirometer software determines the start of forced exhalation by drawing a line down the steepest part of the volume versus time tracing, as shown here with this red arrow. Time zero, the start of forced exhalation, starts where this line intersects the horizontal axis that time is measured on. The back extrapolated volume is the volume of air that was leaked out of the patient's lungs before they did the forced spirometry. So the back extrapolated volume is determined by measuring any volume that was exhaled here before time zero, as shown here by the dark arrow. Excessive back extrapolated volume is an important error to identify and correct because it may result in an inaccurate FEV1. The FEV1 will be higher because the volume of air that the patient exhales prior to forced exhalation becomes part of the FEV1. So the FEV1 obviously is supposed to be measured over the first second of forced exhalation, as shown here in the black arrow, time 0 to 1 second. However, the red arrow shows that this volume of air was exhaled. Volume is measured vertically here. This volume of air was exhaled before time 0 began, and that will make the FEV1 falsely high. It may be difficult to eliminate all back extrapolated volume, but how much is too much? In the 2005 American Thoracic Society European Respiratory Society standards, greater than or equal to 150 mLs or greater than 5% of the forced vital capacity, whichever is greater, was deemed to be unacceptable. In 2019, the ATS-ERS standard lowered that to greater than or equal to 100 mLs or greater than 5% of the vital capacity, whichever is greater. So more than that is thought to be enough to affect the accuracy of the FEV1. Why does this happen? I don't particularly care for the term excessive back extrapolated volume. It doesn't seem to be very descriptive, and it creates a fair amount of confusion. I think a better term would be a false start, similar to football when one of the linemen move before the ball is hiked to the quarterback. Essentially what's happening is that the patient takes a full inhalation and lets some air leak into the spirometer before performing forced exhalation. It is important to note that even with good effort and cooperation, this may occur in patients with neuromuscular disease or upper airway obstruction simply because they're not able to perform a strong forced exhalation. There's also a situation that can create false back extrapolated volume, and this situation is called a positive zero flow error. A zero flow error is present when the spirometer is measuring flow and volume changes when the patient isn't even connected to the mouthpiece. A zero flow error can be negative or positive. A negative zero flow error means that inspiratory flow is falsely recorded, while a positive zero flow error occurs when expiratory flow is falsely recorded. A zero flow error can be caused by low flows entering the spirometer when it's zeroing. So, for example, the patient is breathing towards the spirometer, or if you have a fan in the room or air conditioning flow in the room can cause this. Usually this is easily fixed by just clicking the zero flow function. You might want to put your gloved hand over the end of the spirometer to make sure there isn't any flows from the rooms entering when it's zeroing. The positive zero flow error can cause false extrapolated volume because it's recording expiratory flow even if the patient isn't breathing. And as you can see here in the graphic, even when the patient is not connected, the volume measurement is going up from this error. How is excessive back extrapolated volume detected? Well, the software of all modern spirometers is going to give you an alert. As you can see here in red, is telling you that the back extrapolated volume is excessive. In addition to the error alerts from the software, you really need to be able to identify these poor starts on the flow volume loop and the volume time curve. I often reject efforts with back extrapolated volume, even if the software doesn't flag it as excessive, because I know with good coaching, I can usually get better results. So as you can see at the top, with the flow volume loop, on the flow volume loop, volume change is measured horizontally. So you can see that this amount of air was exhaled by the patient at low flows before they did the forced exhalation. I've shown you on previous slides the volume time curve, where you can see that volume was exhaled before time zero, and that would indicate back extrapolated volume. If you have identified that excessive back extrapolated volume is present, what can you do to coach your patient to eliminate this error? Well, firstly, you want to ensure that there isn't a positive zero flow error. I think you should have the patient always start spirometry tidal breathing on the mouthpiece. When the patient holds the mouthpiece in their hand, takes a full breath in, and then tries to put the mouthpiece in their mouth, they may have difficulty doing that, and some air leaks out. So I always think it's better to start with tidal breathing on the mouthpiece. Of course, you want to explain the error to the patient and show them graphically, as I just did on the previous slide. It's always important to instruct the patient to blast the air out immediately. Don't blow, don't push, blast it out immediately. If the patient takes that full breath in and they hold their breath at total lung capacity, that should always be less than 2 seconds. If the longer they hold their breath, the more likely they're going to leak. When patients are having problems with this error and I'm trying to explain to them, I use this analogy that you're basically in a drag race and the light is turning green. And as soon as it turns green, you're rolling a few feet before you hit the throttle. So as soon as the light turns green, hit the throttle. Another strategy that's pretty effective when you're having this problem is to allow the patient to do the spirometry maneuver on their own. Sometimes we don't make great dance partners, so I'll tell the patient, okay, just do it on your own. You start off breathing normally. As soon as you're ready, take a full breath in. As soon as you feel completely full, blast out the air immediately. A word of caution. If you allow the patient to do the spirometry maneuver on their own, be watchful for incomplete inhalation prior to forced exhalation. Sometimes the patient is so focused on performing a good blast that they do it prematurely before they have completely inhaled. An incomplete inhalation will result in a reduction in both vital capacity and FEV1. Sometimes you can detect this error on the inspiratory limb of the flow volume loop. As you can see here, this is where the patient performed the blast, the forced exhalation began. They exhaled all this air here, and then when they inhaled back in, they exceeded the point where they started. So the inspiratory volume here is larger than it was before they did the forced exhalation. The key points to remember: excessive back extrapolated volume occurs when the patient lets some air leak out before performing the forced expiratory maneuver. Greater than 100 mLs or 5% of the vital capacity is deemed to be unacceptable. Excessive back extrapolated volume may cause a falsely higher FEV1. Back extrapolated volume can be identified with software alerts and with the inspection of the flow volume loop and the volume time curve. The good news is this is usually a correctable problem with good coaching. Thank you for watching PFT Tutor with Jeffrey Haynes. Please click the like, subscribe, and notification buttons, and we'll see you next time.